Thanks very much to everyone for inviting me. This is the first time I've come to the Treatment as Prevention workshop. And since a lot of my career, both at the World Bank for 20 years and then at the Center for Global Development, has been about the absolute need to prevent HIV infection in order to be able to treat the people who are sick. I'm very glad to see that treatment is now contributing to prevention. But my job today is not going to be to talk about treatment. That's going to be Jeff's job. And I'm going to be trying to suggest to you that even in this era when we know that treatment will prevent infections, behavior is still a cost-effective investment. So I want to try to address these three propositions and see if I get some resonance in the audience for all three of these. The first one is, I don't think anybody in the room believes that individual behavior has no relevance to the epidemic, but I'm asserting something a little bit stronger than that, that it's the most important determinant of HIV infection and also of treatment success. I'm not going to be talking in this talk very much about the importance of behavior for treatment success. It's something I've worked on in other contexts, and we've had a lot of discussion about the determinants of good adherence already in this workshop. So I think it would be cheating a little bit for me to talk about that topic, which is a relatively easy sell. Instead, I want to talk primarily about the importance of behavior for the prevention of HIV infection. But believing that it's important is not sufficient, of course, for us to allocate resources to it. We have to believe also something that many people do not believe, and that is that risk behavior is partly under an individual's control and thus responsive to incentives. In 1995, when I was working at the World Bank and assigned the task of writing the first economic report entirely devoted to the HIV/AIDS epidemic, I and my co-author Martha Ainsworth approached Richard Feacham, who was then the head of the health sector at the World Bank, and asked for his support. And he said that AIDS is actually not a very important topic in the health sector. This was in 1996. And part of the reason for that is that sexual behavior, he said, is immutable. So later he became the director of the Global Fund and had a very different view, both about the importance of the AIDS epidemic and also ultimately about the mutability of sexual behavior. But this is just to tell you that, in fact, the idea that sexual behavior is under the individual's control and is mutable is to some degree disputed. So I want to present some studies out there, and I believe there are actually a great many more that I will not have time to talk about that contradict that view. And thirdly, I want to argue that the government can actually employ incentives to alter people's risk behavior. And this is of course the point of our whole talk, it can do so cost effectively in a situation where we have limited resources and those resources have to be allocated among various strategies. I'm arguing that far too little is being spent on behavioral interventions. So the first of these three assertions is one that, is not going to be accepted by everyone. But I had the great fortune at the beginning of my career to work with Jonathan Mann. I was seconded by the World Bank to WHO, to the WHO AIDS program in its early stages before the existence of UNAIDS. And a story that was common in the WHO building is one that I think is relevant to this. Just as the AIDS program was beginning under Jonathan Mann's tutelage, he held a meeting of all WHO staff in the main amphitheater of WHO for the staff, and he gave a talk about AIDS. And after it was over, there was a show of hands. He called on a lady who was somewhat elderly, sort of like me now, and with gray hair. As you may know, WHO was staffed by many, many British ladies for a long time. And this was one of those ladies, estimable person, who raised her hand and asked, "Is it possible, Dr. Mann, to get AIDS from a toilet seat?" And his response was, "Well, ma'am, it depends what you do on the toilet seat." So I think all of us recognize that behavior is important, and without risk behavior, there would be little infection, in fact. So just a couple of points on this to show you that this idea has been around a long time, but relates to things that we're already hearing come back in a big way right now. Brian Williams told us in his presentation on Vietnam that the epidemic would only have an R0 value of somewhere in the small single digits, possibly 1 or 3, 1 to 3, something like that, if it were not for this extraordinarily high transmitting group of IDUs who are also female sex workers. And those, the intersection, union of those two groups is important. The intersection of them is even more important. And together, he said, they raised the R0 value for that epidemic to 22. So I think that's a sufficient demonstration, and I can quote Brian here, to support the hypothesis that behavior is extraordinarily important in driving this epidemic. And in that book that Richard Feacham did not support at the time, but that was published despite his opposition, we actually have a story there that's not so different from the story that Brian told in his talk on Vietnam. We reached out to an eminent Canadian epidemiologist named Stephen Moses. Stephen, are you here actually? I haven't seen you, but Stephen, many of you will know Stephen, and he helped us work this out based on his Nairobi cohort of sex workers, that you could choose to try to change the condom use of 500 sex workers or 500 low-income men. But due to the differences in their behavior, the same differences to which Brian was alluding, the benefit he estimated would be far, far greater if you targeted those interventions based on the behavior of the individuals concerned. And in fact, of course, we know that that Nairobi sex worker project was extraordinarily successful in increasing condom use up to 80%. But it's a little bit, it's one thing to say that behavior is important. It's another to be convinced that it's under the individual's control and thus responsive to incentives. Well, in fact, the change in behavior, the condom behavior of those Nairobi prostitutes is one example that behavior is under an individual's control. Even these very poor prostitutes who are certainly disadvantaged, and many would argue have little choice, have few choices. But I want to point to a couple of other studies that actually allow us to reject the hypothesis that women cannot control their sexual behavior. There's a fascinating study by Pascaline Dupas when she was a professor at Dartmouth. She did this study jointly with the Poverty Action Lab folks, and she showed that an education subsidy and jointly with a national HIV curriculum in this randomized controlled trial in Kenya, 7 years later showed a statistically significant benefit, both in reducing teenage marriage and, actually this is wrong, the second bullet there is wrong, and in reducing HSV-2 transmission. So that's one demonstration that actually the education subsidy and the curriculum together could have that difference. The study in Malawi, much more recently by Berk Osler, Sarah Baird, and McIntosh, gave education grants, and they had a control arm and an experimental arm, and they were able to show both 60% lower prevalence of HIV and 75% lower HSV after about 18 months. And the mechanism by which the women in that study lowered their HIV prevalence was that they chose to have relations with younger men. So sometimes we refer to those older men as sugar daddies, and the hypothesis is that the girls need the money from those men in order to afford education expenses. those women, apparently, those young women, those girls, when they did have access to this cash to pay for their uniforms, to pay for their tuitions and their books, they no longer sought the sugar daddies and chose instead as sexual partners younger and presumably more attractive men. There's also a study by Pascaline Dupas that shows that pregnancies by older men in particular go down dramatically if you talk to the women about the risk of HIV infection from an older man. Look at these enormously large treatment effects. Another study that shows the mutability of behavior is an interesting one in which individuals were randomized to receive $10, $20, or nothing if they were STI-free after 4, 8, and 12 months. And in this study, the $10 incentive was not enough to show a statistically significant effect in this small sample, but the $20 benefit of being STI negative did show effect, significant at the 0.05 level. And notice that that 73% hazard ratio is the same hazard ratio that the recent Chinese study showed for the reduction in transmission in using treatment as prevention. So you get about a 27% reduction in that population study in China if you use treatment as prevention, and here you're getting the same effect, about a 27% reduction in prevalence due to simply paying $20 for people to change their sexual behavior. So can the government actually use incentives? Can it intervene with incentives in order to affect people's risk behavior? And can it do so cost effectively? Well, I want to come back to another study that shows that government policy does in fact affect risk behavior. But this is a study that actually demonstrates, I believe, the possibility that we have some significant risk compensation or disinhibition going on. Willa Friedman, in a study of Kenyan's scale-up, where she merged the scale-up data with DHS data on individual behavior and on pregnancy, she has this biological indicator pregnancy, which is really robust. It's not like self-reported sexual behavior. And what she shows, you see the 3 stars next to these 3 different estimates, depending on the method she used. She was using a difference in difference method, like the one that Till Bernenhausen talked about in an earlier presentation. She's seen an 85% increase in pregnancy in the areas where antiretroviral treatment has been rolled out. Now, is that due to biology? She doesn't think so, because the HIV infection rate among this DHS sample was only about 3%. So no way could an 85% increase in fertility could be explained by the biological benefits of antiretroviral treatment. It must be, in fact, increased fertility behavior because you're not afraid of AIDS. And therefore, this definitely shows that government programs can affect risk behavior. But the more interesting question is whether government programs can affect risk behavior in order to reduce it through appropriate interventions. And this study is from the Avahan project in India, that we know is one of the largest and best run, best managed interventions with sex workers that's ever been done in the world. Now, we've been hearing a lot about cost effectiveness. Almost everybody who puts up a cost number says that they're showing cost effectiveness. And what we're seeing is numbers per DALI averted that look like $1,500, $2,000, even more. And it's declared to be cost effective because it's less than the GDP per capita, or because it's less than 3 times the GDP per capita. Well, I would want to submit to you all that cost effectiveness is not an absolute thing relative to GDP per capita. It's a relative thing. And if there are opportunities to save DALIs, which cost $50 instead of $2,500, and we're leaving those on the table and we're going for the $2,500, then we're not spending our resources most effectively. So when these opportunities with behavioral interventions are in fact exhausted, then I can understand moving on to the treatment as prevention strategy. But until they're exhausted, let's keep pushing on these low-hanging fruit. So now I want to end with something that I think also resonates with Brian's talk on Vietnam. And this is a slide that comes from our report in 1997, that Confronting AIDS document, in which we suggested that in any given population, it would be possible to rank the subpopulations by the riskiness of their behavior from high to low. And that depending on resource availability, remember that's the key phrase that's in the title of our session, depending on resource availability, you would begin by prioritizing the resources towards behavioral change among those who are at highest risk. Now that we know treatment also prevents infection, we would also prioritize treatment for those people. If you have more resources, you're a richer country or you have more generous donor support, then you could reach to people with less risk behavior, and only if you're extraordinarily generously endowed with resources, with staff, and with donor support, might you actually try to cover blanket the population all equally generously with that support. So I hope I've convinced you that behavior is important, that it's mutable, and that it's a cost-effective choice. Thank you very much.